Good day, everyone. My name is Liezel Suarez, and as a nurse, I've been practicing my profession for over a decade, and uh, I've been exposed already to different areas in the hospital, such as in hemodialysis unit, in pediatrics, in NICU, and right now I'm assigned in intensive care unit. And I'm currently taking up Masters of Arts in Nursing, distance learning at Wesleyan University, Philippines. And today I will be your presenter, and I will be using traditional teaching strategy using this PowerPoint presentation. And my topic, our topic is about pain. So before diving to this topic, we have our objectives. So to define pain, then second, to differentiate acute from chronic pain, and then to enumerate the types of pain and their qualities, to discuss the effects of pain, sympathetic and parasympathetic responses, and then to review pain assessment tools, and to discuss pain management therapy. So what is pain? Pain, it is unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain may not be directly proportional to amount of tissue injury and highly subjective, leading to undertreatment. And it is considered as a fifth vital sign. So we nurses must be particular with this sign and include it during vital sign taking. Then we have classification of pain. So we have acute and chronic pain. So first, what is acute pain? So acute pain, it is an injury, trauma, spasm, or disease to skin muscles, somatic structures, or viscera, perceived and communicated via peripheral mechanisms, pathways, and usually associated with autonomic responses such as blood pressure, pallor, diaphoresis, yeah. And then usually subsides quickly as pain-producing stimuli decreases. Associated with anxiety, decreases rapidly, and can be understood or rationalized as part of the healing process. Then we have here chronic pain. So chronic pain has two categories. We have non-malignant and malignant. So first, the non-malignant. Pain persists beyond precipitating injury, rarely accompanied by autonomic symptoms. Sufferers often fail to demonstrate objective evidence of underlying pathology and characterized by location visceral, myofascial, or neural causes. And then we have malignant. Malignant has characteristics of chronic pain as well as symptoms of acute pain, breaking through pain, and has a definable cause, for example, tumor recurrence. So here we have types of pain. So first we have cutaneous. So cutaneous pertains to skin, superficial. And then we have somatic pain. So it pertains to the muscles, joints, and bones. It means deep. And then we have visceral pain. So it pertains to the organs. And then we have phantom pain. It means missing or gone. So for example, the patient is complaining right knee pain. However, that right knee was being amputated several years ago. So right now the patient is suffering from phantom pain, and the best treatment for that is through mirror therapy. And then we have intractable pain. So without relief unless undergoing surgery. And then we have psychogenic pain. So without it is without physiologic basis. such as emotional stress. And then we have referred and radiating pain. For referred pain, it is perceived on the other side. For example, cholecystitis. So, um, the gallbladder is situated in the right upper quadrant. However, the patient is complaining right shoulder pain. And then we have radiating. So radiating means extension. So the pain is extended to the other parts of the body. Like the best example is herniated disc. So the patient is suffering from lower back pain, and then it extends or runs down to his legs. Here we have effects of pain. We have sympathetic and parasympathetic response. So in sympathetic response, we have increase in blood pressure, increase in pulse, respiration, patient is suffering from muscle tension, diaphoresis, and even pallor. Meanwhile, the parasympathetic responses are decrease in blood pressure, decrease in respiration, pulse, patient is suffering from nausea and vomiting, weakness, and even loss of consciousness. Then we have here pain assessment. So I have here an acronym. The PQRST, for me, it's the easiest and best way to assess pain. And so we have P. P means provoke. So what activity provoked the pain? And then we have quality, no close-ended or suggesting, just plainly own description of the patient. And then we have region, location. And then we have S for severity. So here we are using pain scale, either numeric, 0 to 5, 0 to 10, or using Wong-Baker spaces. So we have here, for example, 0, it means no pain, 1 to 2, mild, 3 to 4, moderate, 5 to 6, severe, 7 to 8, very severe, and 9 to 10 is worst pain possible. And then we have the numeric 0 to 5. 0 means no hurt, 1 hurts a little bit, 2 hurts a little more, 3 hurts even more, 4 hurts whole lot, and 5 hurts worst. And of course, T for time. Don't forget the time, the onset, duration, and interval. So after pain assessment, we have pain management. So we have opioids, narcotics. These are CNS depressants, so such as morphine, fentanyl, oxycodone. And then we have non-opioids or NSAIDs. So these are ibuprofen, acetaminophen, and celecoxib. And then we have co-analgesic, the adjuvant. So these are Benadryl, diazepam, and so we have here 3-step ladder from WHO. So the drug of choice depends on the intensity of pain. And then here we have step 1, mild pain. So you can use non-opioid plus minus adjuvant therapy. And then we have step 2, mild to moderate pain. So you can use weak opioid plus minus non-opioid plus minus co-analgesic. And then on the third ladder, we have moderate to severe pain. So you can use strong opioid, non-opioid, plus minus co-analgesic therapy. Oh, that's the end of the slide. So it means that's the end of my report. Hope that you were able to learn something from it and you will able to digest, grasp the things that are necessary in uh, in assessing pain. So that's it. Thank you for your time.